Thank you, Bill. Really appreciate it. And thank you for this honor. And I'm going to start with an honor to Pat Fleet. Pat Fleet was one of my first attendings in nephrology. He was my mentor. He was my friend. He passed away February 28th, and I owe a lot to him because he took the time to, as he has with many other people, has taken the time to teach. So I just wanted to honor him with this talk and dedicate this talk to him. This is also World Kidney Day, so it's fortuitous that I'm a nephrologist giving a talk today on World Kidney Day, so everyone think about your kidney health today. So as is common practice, I'm going to start with a case. The case is Mrs. J, and she's an actual patient of mine. She's a 56-year-old African-American female. She came to clinic with an elevated creatinine. She has a history of hypertension, obesity, diabetes that she's had for over 10 years. She has a family history of kidney failure in 2 relatives. And when we saw her in clinic, her blood pressure was 170/90. Her lungs were clear. She had a regular rate and rhythm heart exam. Her abdomen was non-tender, and she had 2+ edema in her lower extremities. Her laboratory tests showed that her creatinine was 2. Her eGFR calculated was 20, and her hemoglobin A1C was 8.5, which is elevated, and her diabetes was not well controlled at the time. Her renal ultrasound showed that she had normal kidney size and shape, and the question posed was, what is her underlying cause of her kidney disease, and how should we approach her workup? So I want you to keep this in mind as we talk about kidney disease in African Americans. And this talk will really focus on kidney disease in African Americans because that's been the bulk of my research. And so the objectives will be to discuss the epidemiology of kidney disease, review the social and biologic determinants of health and associations with chronic kidney disease, and then discuss APOL-L1 or apolipoprotein L1 in kidney disease and the ethics of genetic testing, which is what the research that I'm doing now. So we'll start with discussion of the epidemiology of kidney disease. So chronic kidney disease is prevalent. African Americans have a 3- to 4-fold greater incidence of kidney failure compared to whites, and end-stage renal disease, which is kidney failure that needs dialysis. And compared to whites, other minority groups also have higher rates of end-stage renal disease. African Americans comprise about 32% of dialysis patients, but only about 12% of the US population. And if you go to dialysis units in the South, there's probably about 80% dialysis patients are African American compared to up here in the Northwest. So these are the different stages of chronic kidney disease, and I put this in just to give you an idea of what those are. So stage 1 is kidney damage or with normal or increased GFR. So we measure GFR by a calculation, and anything greater than 90 is considered normal, and that's about 3.6 million of the population. Stage 2 is a mild kidney damage or decrease in eGFR of 60 to 89. It's about 6 million. And stage 3 is a moderate decrease in GFR, or anything that's 30 to 60 mils per minute per 1.73 meters squared, about 14 million. And stage 4 is a severe decrease in eGFR of 15 to 29, which is about 7 million. And stage 5 is kidney failure, so either an eGFR less than 15 or on dialysis. So back then, these numbers equaled about 26 million, so a few years ago. And now it's estimated that there are about 37 million people who have chronic kidney disease, and that's about 15% of US adults. Many people don't know that they have kidney disease, and about 1 in 2 people have very low function, kidney function, who are not on dialysis or know that they have chronic kidney disease. So approximately 1 in 7 adults has kidney disease and may not know it. So when we look at end-stage renal disease, or people who are on dialysis, African Americans have always had a higher incidence and prevalence of end-stage renal disease compared to whites. Native Americans also have a high incidence that has been decreasing, and this decrease has been due to much more aggressive treatment of diabetic kidney disease, which was the #1 cause of end-stage renal disease. if we look a little bit closer at sort of this trend, this downward trend, African Americans still have like a 3- to 4-fold greater risk of end-stage renal disease compared to whites. And if you look at Hispanics, that trend is also true, that there's an increased risk of end-stage renal disease. So these are some new graphs that have been developed by the United States Renal Data System, and these, the USRDS actually keeps track of all the people who go on dialysis. And what this graph shows that if you look at the cumulative incidence of end-stage renal disease from birth, and by age, African Americans tend to start having end-stage renal disease almost 15 to 20 years sooner than whites and other populations, which is incredible. So this is the cumulative lifetime incidence of end-stage renal disease for men, and this is that same graph for women. So African Americans really have this higher sort of risk of end-stage renal disease that we really haven't been able to ascertain the reasons why. So next, I'm going to review some of the social and biological determinants of health and associations with chronic kidney disease. So determinants of health include individual health, and we'll stick with individual kidney health since that's what our talk is about, my talk is about. And so what can factor into that? Policy making, access to health services, what someone's social and physical environment is, what their individual behavior is, and what either biology or genetics can contribute to individual kidney health. So we'll go through some of the studies that we've been doing over the past like 10 years that sort of deal with these determinants of health. So we'll start with policy making. So the Medicare end-stage renal disease program was one of the first national health insurance programs for anyone who had stage 5 chronic kidney disease. It pays for all US citizens of any age for dialysis and transplant. And this program was established by Congress in 1972, signed into law by President Nixon in 1973, and accounts for probably about $110 to $114 billion of the Medicare budget. So we pay a lot for dialysis, but patients have to actually go into renal failure in order to be able to get access to this program. So you basically have to go into kidney failure to have access to health insurance if you don't have any at all. So what about health services? A while ago, like 10 years or 15 years ago, we looked at whether or not access to care actually helped explain some of the differences between whites and blacks and other minority groups in regards to diabetes, which is the #1 cause of end-stage renal disease. So we looked at racial and ethnic differences in microalbuminuria at a group, then Group Health, now it's the Kaiser. And what we found is that African Americans had more microalbuminuria compared to whites, even though they had equal access to care. We did the same study and looked at diabetes and kidney disease in veterans and found that African Americans and other minority groups had earlier signs of kidney disease compared to whites. And then we looked at other complications of diabetes, including diabetic kidney disease, heart disease, and mortality in a national VA population, and found that African Americans and other minority groups had higher rates of diabetic nephropathy, but lower rates of cardiovascular disease and mortality in veterans who have equal access to care. So we also looked at whether or not access to the U.S. to end-stage renal disease treatment or dialysis decreased complications in minority groups. So this is a study of in the USRDS, where we looked at minorities and looked at whether or not there was complications like myocardial infarctions in minority groups. And what we found is that African Americans, Asians, Hispanics all had lower rates of cardiovascular disease compared to whites once they started dialysis. So we sort of concluded that if you had access to care and access to treatment, that maybe some of the complications that we see maybe decrease because people have access to care. So what about social and physical environment? So this just came out this week. This isn't my study, but this is a study that was done on Upper Campus where they looked at the brunt of pollution. And so blacks and Hispanics are actually exposed to more pollution nationally. So we know that there are environmental causes to lots of diseases, and pollution is one of the things that actually there's a sort of racial ethnic difference. So in order for us to look at some of these determinants of health, we started to work on data from the Jackson Heart Study. So the Jackson Heart Study is a prospective NIH-funded study of cardiovascular disease in African Americans. It involves about 5,300 African Americans who were recruited from Jackson, Mississippi. There were 3 exams, and data were collected at 2000 to 2004, 2005 to 2008, and 2009 to 2012. And they just received funding for exam number 4. We were funded to develop a kidney disease national working group to look at kidney disease outcomes. And so this is just a schematic of the Jackson Heart Study. So longitudinal data was captured annually. The main outcomes that they were interested in were cardiovascular disease, stroke, and heart failure. And we were funded to look at end-stage renal disease and kidney disease. And so one of our first objectives was to identify risk factors for rapid kidney function decline amongst African Americans. And so we started out with the full Jackson Heart Study, excluded people who didn't have any creatinine at baseline or at the visit 3, which is a span of about 10 years. And so we had about 3,600 subjects to do analyses on. And we had to impute some albumin studies because they didn't have them on all the subjects. So this is the Jackson Heart Study cohort. The whole cohort was about 5,300. Our analysis cohort was 3,600. And so people were recruited at baseline. They're about in their mid-50s. The majority were women. There was about 12% who were low income. 16% had an education less than high school. Many had private insurance. BMI was elevated, and blood pressure was normal, as was creatinine on average, and about 20% had diabetes. The majority, 60%, had hypertension and didn't have evidence of kidney disease at baseline. And so we looked at risk factors for rapid kidney function decline, and that's defined as an estimated GFR decline of greater than 30% over 10 years, so more than 3 mils per minute per year. And what we found is that as people age, their odds of having this rapid kidney function decline increase. It was about, these are odds ratios. So for every 10-year increase in age, there was a 1.8-fold greater risk of rapid kidney function decline. For those who were in low income, they had a 1.8 to 2-fold greater risk of rapid kidney function decline. If they were sort of less well educated, they had a 1.9-fold greater risk of rapid kidney function decline. For increases in blood pressure, it was 1.3-fold, diabetes 1.7-fold, and if they were a smoker, 1.9-fold, and baseline cardiovascular disease 1.5-fold. So what this study showed is that CKD was prevalent. It was prevalent in about 11% of the African Americans at baseline. The risk factors for rapid kidney function decline included socioeconomic status, age, diabetes, hypertension, cardiovascular disease, and smoking. And when we looked at BMI and increased waist circumference, those were not really risk factors. So now looking at individual behavior, there were more investigators who were interested in smoking and looking at that risk factor. And so we know smoking is associated with lung cancer and an increased risk of heart disease. And we always, in primary care, want people to stop smoking, and we recommend it and have it as a preventive measure. But prior to our first study, there wasn't a consistent association with kidney disease development. Dr. Hall, who's a cardiologist down at University of Mississippi, wanted to look at smoking and kidney disease, and what he did is there's some data on whether or not people were current smokers, past smoker, or never smoker, and he looked at the estimated GFR, kidney function, at baseline in visit 1, and then at visit 3, which is about 8 to 10 years after visit 1, and looked at the change in eGFR. And what he found is that for current smokers, there was about a 12 mils per minute per meter squared change in eGFR. For past smokers, it was minus 9.8 mils per minute per meter squared, and for never smokers, about 8. So it doesn't seem like that's very much of a difference. But when you put that all into a logistic regression or a incidence regression model, what he found is that for those who never smoked, if you were a past smoker, you had about a 1.2-fold greater risk of rapid kidney function decline. If you were a current smoker, it was up to about 1.7, and it really depended on the number of cigarettes that you smoked. So if you smoked more cigarettes, you actually had a faster risk of rapid kidney function decline. So this was very interesting in terms of smoking. Next, there's an investigator, her name is Casey Rebholz, who was interested in beverage intake. And so she was interested in whether or not drinking beverages that had high glucose or sweetened fruit beverages was associated with incident kidney disease. So she looked at the Jackson Heart Study. There's about 3,000 people that she investigated. They did a food frequency questionnaire at baseline, and her outcome was incident chronic kidney disease. She put them into a model where she adjusted for things like age, what their total energy intake was, their gender, education, smoking, what their activity was, hypertension, diabetes, all these risk factors for kidney disease, and developed a scoring mechanism to look at those who had high soda intake and high sweetened fruit drinks and high sort of glucose water intake. And what she found that is if you had a higher intake of these sort of sweetened beverages, there was a higher incidence of chronic kidney disease. This was very interesting because it looked at sort of potentially modifiable factors, and it's important since we now have this tax on sodas here in Washington. Maybe we're going to be helping with development of kidney disease. So next is biology and genetics. So I'll spend a little bit more time on these two determinants of health. And to start with, we're going to start with heart failure. So heart failure is highly prevalent in African Americans compared to whites, and less is known regarding how heart failure, heart disease, and stroke differ in people with kidney disease. So this is a study that was done by Dr. Nisha Bansal, who's actually here today, who looked at heart failure in the Jackson Heart Study, MESA, and the CHS, the Coronary Heart Study, Cardiovascular Health Study, and she looked at heart failure in people who had chronic kidney disease versus no kidney disease. So if you just divided and looked at unadjusted incidence rates of heart failure, coronary heart disease, and stroke, what she found is that those with kidney disease had higher rates of heart failure, higher rates of coronary heart disease, and higher rates of stroke. So what was very interesting for me was when she looked at the Jackson Heart Study. As part of that, the Jackson Heart Study participants had a much higher risk of heart failure compared to MESA and the CHS population. And African Americans and Hispanics also had this higher risk of heart failure if they had chronic kidney disease. So this is very interesting, something that we're very interested in pursuing and looking at, potentially looking at mechanisms for this. So another study that was done was looking at sickle cell trait and chronic kidney disease. So sickle cell trait, as you know, is inherited as a single copy of the hemoglobin S gene. It affects about 1 in 12 African Americans, but it affects probably 300 million people worldwide. And we know that sickle cell disease itself, if you're a homozygote, is associated with kidney abnormalities that include decreased urinary concentrating ability, chronic kidney disease, and end-stage renal disease. So what was not known at the time was whether or not people who were heterozygotes for sickle cell trait or heterozygotes for sickle cell disease had an association with kidney disease. So we hypothesized that sickle cell trait was associated with the development of chronic kidney disease. There is a hematologist, Dr. Naik, who put together 5 different population studies: the ERIC study, atherosclerosis risk and community study, Jackson Heart study, which we were a part of, the coronary artery risk development in young adults, or the CARDIA study, the multi-ethnic study of atherosclerosis of MESA, and the Women's Health Initiative, and looked at primary outcomes of prevalent chronic kidney disease defined as an EGFR or estimated glomerular filtration rate less than 60, incident chronic kidney disease as defined by this EGFR, albuminuria or albumin in the urine, or rapid decline in EGFR greater than 3 mils per minute per meter square per year, or about 30% over 10 years. She used logistic regression and adjusted for age, sex, African ancestry, diabetes, and hypertension, and did a meta-analysis of all these different cohort studies. And I'm not going to show you all the data, but I'll show you a couple of the slides from this paper that showed that sickle cell trait was associated with incident chronic kidney disease in African Americans. So there's a 79% increase in the odds of incident chronic kidney disease. And if you look, we looked at EGFR decline, there's a 32% increased odds of EGFR decline, which was consistent with all the studies that were done. So for sickle cell trait, there was an association with prevalent chronic kidney disease, incident kidney disease, EGFR decline, and albuminuria in this large pooled cohort of almost 16,000 African Americans. So it explains a portion of the racial differences in kidney disease, but it doesn't explain all of the increased risk. With my remaining time, I'm going to talk about APOL1 and kidney disease and go through some of the ethics of genetic testing. So people who've heard me talk about this have seen this slide before, and I put this up to ask people, what if you could know everything about your genetic makeup? There are a lot of ads out there for Ancestry.com, for 23andMe, and they give you a lot of information about genetics. Sometimes that's information that you want, sometimes it's not, but it's very interesting, and now it's available to us all. So in terms of genetics, we, as a sort of research enterprise, we have been looking for some cause for differences in kidney disease for African Americans. And in 2010, Dr. Bessie and Martin Pollock actually found that there's an association of what's called trypanolytic APOL1 variants with kidney disease in African Americans. So this was published in Science, and the story is that apolipoprotein L1, or APOL1 as we call it, is a genetic variant that is associated with protection from trypanosomes, which are the cause of African sleeping sickness. You get trypanosomes from the tsetse fly, and those are trypanosomes in red blood, with red blood cells in the bloodstream. These variants are resistant to the lethal form of trypanosomiasis, and it's thought that these variants arose about 3,000 to 6,000 years ago in sub-Saharan Africa as an ecological pressure to trypanosomiasis. These variants are present only in people of African descent so far, or people who have West African heritage, and if you're considered a high-risk genotype if you have 2 of the high-risk variants. So these variants include G1 and G2. G1 has 2 amino acid substitutions, and G2 has 2 amino acid base pair deletions. And G1 was found to be present in about 40% of the Yoruba tribe from Nigeria in West Africa when it was looked at in the HapMap evaluation that looked at data from the Yoruba tribe, Europeans, Japanese, and Chinese. So it is thought that about 30% of African Americans have either G1 or G2, or both, and about 13% of African Americans have high-risk variants, either G1, 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 G2, or G2, G2. And it's thought that African Americans have these high-risk variants because many of the slaves came from West Africa. So they would make the trek over the Middle Passage. They would go and land in the West Indies, and they would be brought into North America in exchange for goods and other things from Europe. So when people have looked at the distribution of G1 and G2 APOL1 variants across Africa, and they found that G1 is in the blue, G2 is in green, and the wild type, or the normal phenotype, is in red. So in this part of West Africa, there are higher G1 and G2 variants in people in these areas here. There's some variants down here in South Africa, but less in East Africa, and less up here in like sort of Ethiopia. And so the structure of APOL1 and kidney failure, so this is the domain that is phenotypically different. This is the wild type, and this is, these are the two amino acid substitutions, and this is the area where the amino acids are deleted. So this is just a cartoon that shows that if you have the normal wild type allele, you're more susceptible to trypanosomiasis, and the lethal form of trypanosomiasis where people actually can die. If you have one risk allele, then you're protected from trypanosomiasis, and if you have two risk alleles, then you are also protected, but you're more likely to develop kidney failure. And so the first studies that showed this showed that African Americans with these APOL1 variants had increased risk of end-stage renal disease. And so focal segmental glomerulosclerosis is a disease where you have scarring in the glomerulus. It's associated with protein in the urine and disproportionately affects African Americans. And when they looked at a case control study of people who had focal segmental glomerulosclerosis, they found that if and these were in African Americans, if they had the APOL1 phenotype, high-risk phenotype, they had a 10-fold greater risk of end-stage renal disease. They also looked at this in hypertensive-associated kidney disease, and there was a 7.3-fold greater risk of end-stage renal disease if they had the high-risk APOL1 genotype. And in HIV-associated nephropathy, or HIVAN, which is thought to be a disease that affects primarily African Americans, if they had the APOL1 phenotypes, they had a 29-fold greater risk of end-stage renal disease. And that's shown here. Transplantation, there have been several studies that have showed that there's an increased risk of progression of kidney disease and development of kidney failure. So, and these odds are just unheard of in terms of risk of kidney disease. So people really felt like they had the gene that was associated with kidney disease for African Americans. So just to review some of the data, I won't go through all of them. APOL1 high-risk genotypes have been associated with decreased renal function over time. The declines are greatest in those who are in the high-risk genotype group. And there's also been studies in children who have FSGS and other types of kidney disease that show that if they have the high-risk genotypes, then they have a faster decline of their kidney function compared to those without. So this is a paper by Parsa, who looked at the African American study of kidney disease and showed that if you had 0 or 1 copies of APOL1, you basically you had better survival of your kidney disease compared to people who had 2 copies of APOL1 risk variants. So this is patients who were free from the primary outcome, which was doubling of the creatinine and end-stage renal disease, and this was over time. And the 2 copies of APOL1 was associated with faster progression. Carmen Peralta, who is an investigator at UCSF, also looked at APOL1 in the Cardia study, and she looked at eGFR by cystatin C decline, which was faster for those who had the high-risk APOL1 variants in blacks compared to whites. So we'll go through this slide. The dark line are the high-risk black population. The sort of decreased black line is the low-risk population, and the sort of stippled line is the white population. So those who had the high-risk variants, these squares represent albuminuria, or albumin in the urine. So high-risk blacks had the onset of albuminuria that occurred earlier in terms of age compared to whites and those who had the low risk variants, and they had a faster decline in their eGFR. So once they developed proteinuria or albuminuria, their kidney function declined pretty quickly. And so we also looked at this in the Jackson Heart study, and these are data that Ronit Katz analyzed for us. We looked at APOL1 and albuminuria, development of dialysis, chronic kidney disease, and kidney function decline in the Jackson Heart study. So most of the studies were done comparing patients and subjects who had 0 and 1 allele versus 2 alleles. And so if 30% of the African American population has 1 allele, then we were interested in seeing whether or not 1 allele was associated with early kidney disease. So if we looked at incident albuminuria, there was a 1.5-fold greater risk of incident albuminuria compared to in people who had 1 allele compared to no APOL1 high-risk alleles. And if you had 2 alleles, you had a 2-fold greater risk of incident albuminuria. Dialysis risk increased 14-fold for those who had 2 risk alleles. There wasn't a difference in terms of incident chronic kidney disease, and decline in eGFR or rapid kidney function decline was really only in the people who had the 2 risk alleles. And this just shows it a little bit differently. So albuminuria was present in those who had 1 risk allele, and this is at 8 to 10 years of follow-up. Dialysis was significantly higher in those with 2 alleles, and then there was a rapid decline in kidney function. Just to step back, APOL1 is just really associated with increased risk of end-stage renal disease, faster progression, quicker incidence of incident kidney disease for African Americans and those who have African ancestry. So let's go on to individual kidney health. And now I'm going to talk about the ethics of genetic testing. So now we have these different genetic tests, and people are starting to use these tests in terms of screening people for APOL1 in terms of kidney transplant. And one question is, should we be doing that now, or should we not be doing that? And do we need more information? And what do we do with all of this information? So this is a picture of the Tuskegee study. And there is a legacy of mistrust in the African American community, mainly because of this study. There's also a legacy of mistrust due to sickle cell testing that was rolled out in the 1970s and was associated with mistrust in the Black community. And in terms of just testing for genetic diseases, as nephrologists and polycystic kidney disease, we have a policy of don't ask, don't tell, especially if adults are diagnosed with polycystic kidney disease and they have children who may have polycystic kidney disease. If you test someone for polycystic kidney disease, it's a pre-existing disease. So if you don't have insurance, you might not be able to get insurance if you actually have a diagnosis of polycystic kidney disease. So that may change as people have more access to health care, but I think it's still an issue. So in terms of genetic testing for APOL1 and kidney disease, how should genetic testing be approached? Should everybody be screened? Who has access to the information once someone is tested, and how long is that information kept? So my recent funding with Wiley Burke in bioethics, we address this question, and we got a grant named the Community-Based Evaluation of APOL1 Genetic Testing in African Americans. So our grant consisted of getting key information from key informant interviews, having community conversations with different African American communities, and then having a stakeholder meeting where we could develop policies regarding APOL1, possible guidelines, and educational material for genetic testing. So this study took place in Seattle, Jackson, Mississippi, and Nashville. We did conduct stakeholder interviews and did about 75 of them, and included researchers, clinicians, and nephrologists, primary care providers, and community members who included patients, family members, and other community members. When we asked whether or not we should offer APOL1 testing to all patients, When we looked at what the researchers answered, they categorically said no. And given it's a small number, nephrologists were sort of half and half. Many said no, some said yes. Primary care providers, a few more said yes, we should offer APOL1 testing, but many said no. But when you looked at patients, families, and community members in their reply, they all sort of thought that we should be offering this APOL1 test to all patients. So as the second part of this grant, we had community deliberations or town halls, which consisted of sort of developing and recruiting patients in these 3 different locations. Patients would, or participants would agree to 10 hours of sitting in a room, hearing about APOL1, learning, talking, and discussing with their colleagues. They'd come back for day 2. They would be polled on routine patient care and APOL1, and then kidney transplant and APOL1. And then we summarized and discussed the conclusions at each site. We sent that information back to the community and then came up with some sort of revised and finalized reports that were sent out to the community. And this study was actually just published on Monday. So there was considerable support for optional APOL1 testing in routine patient care and kidney transplantation. And this is a quote from one of the participants in Seattle. We got to know, first thing I would do would be to live a healthier life, change my lifestyle, and maybe they will find a cure at some point or a way to help us better. And then participants expressed the strongest support for APOL1 testing in the transplant setting. So there was near unanimous support for offering APOL1 testing to living donors, potential living donors, and most participants opposed a policy of prohibiting living donors with high APOL1 risk from donating a kidney. As our final component of this grant, we had a stakeholders meeting where we invited our scientific advisory board, our community advisory board, community deliberants from Seattle, Jackson, and Nashville, participants from the NIH, policymakers from the CDC, foundations and societies including the ASN, National Kidney Foundation, American College of Physicians, American Association of Kidney Patients, so the Society for General Internal Medicine, and the American Kidney Fund. And then genetic organizations who had more of a history of knowing what happened when testing for sickle cell disease was rolled out back in the 70s. And so what we found, or the conclusions from that stakeholder meeting included that African Americans should be informed about APOL1 risk. APOL1 testing should be integrated into renal transplant programs. APOL1 testing is not recommended for routine clinical use or screening because there are no specific actions, and this would change as therapies became available. Research is needed to ensure better understanding of APOL1 risk, and involvement of members of the African American community in development of policies and educational material regarding risk and testing is necessary so that the community's needs and preferences are addressed. So this is to summarize the imperative to engage African Americans in this process. And this was one of our Nashville community conversation participants who said, I feel community education and programs are really important in the African American community. When we see the government trying to help us, we may be more likely to do it. I feel like we get the short end of the stick. Black people were strung out on crack for years and nobody cared. White people are strung out on heroin and now it's an epidemic, and now the government has come up with all these programs. I feel like if they did something like that for us, the African American community could see that they do care about us. So they're very powerful statements and very strong feelings in the African American community. So I'm going to go back to our case. So the case of Mrs. J, who was a 56-year-old African American female who had kidney disease and hypertension. She had a kidney biopsy that showed that she had diabetic kidney disease and focal segmental glomerular sclerosis. So was this sort of diabetic kidney disease and FSGS, or diabetic kidney disease and secondary FSGS? I'm not really sure. Her clinical course is that she rapidly progressed to needing dialysis. She underwent a gastric bypass and actually lost a significant amount of weight and was less diabetic. It basically came off all of her medications. And then she received a transplant from her adopted daughter, who was 18 years old, who was found to be APOL1 high-risk positive when she was tested at her transplant center. One transplant center that tested the daughter refused to accept her as a living donor. And so the family went to another transplant center, and she was transplanted. And so now Mrs. J has normal kidney function and is doing well, and her daughter, who is probably now like 20, is a living donor who donated her kidney. So there are lots of questions that need to be answered here. So in conclusion, chronic kidney disease is very prevalent in African Americans. Some people progress rapidly while others don't. There are some novel genetic factors for chronic kidney disease and end-stage renal disease that include the APOL1 polymorphisms and sickle cell trait. Genetic testing for APOL1 is being done, but the ethics of testing need to be further evaluated and defined. And there are new paradigms for genetic testing, and delivering results that involve the community views are needed. So I want to thank you for listening to me and coming out. I want to thank my funders, so that includes the VA, the Division of Nephrology, NIH, and the Kidney Research Institute. I want to thank Dr. Brimner for his support, and Dr. Brody for hers as well, the Division of Nephrology, the VA Puget Sound, and Stuart Shanklin, Rudy Rodriguez, who's been a very strong supporter, Dr. Himmelfarb, Joyce Jackson, who supported me in my quest to become a nephrologist, Dr. Beverly Torg-Storb, who's one of my mentors, Steve Finn, Ed Boyko from the Division of General Internal Medicine, Dr. Wiley Burke, Malia Fullerton, and Erica Blackshear from the Department of Bioethics and Humanities, Dr. Noel Weiss from Epidemiology, and Clarence Spigner from Health Services. The Jackson Heart Chronic Kidney Disease Working Group is a huge group. I want to thank Ronique Katz and Brian Kestembaum, Ian DeBoer, Nisha Bonsall, Leela Selnick, Alex Reiner for all of their help and support. The Sickle Cell Trait Chronic Kidney Disease Working Group includes a lot of people across the country that have helped with that. And I also want to say thanks to all of my mentors and my collaborators, my parents who are both deceased, my husband Marco Milsarek, who some of you may know, and my sibs, my nieces and nephews. And thank you all very much.